Good afternoon, everyone. So I'm gonna, I have a tendency to talk fast, so if I talk too fast, just let me know and I'll dial it down a little bit. I'm gonna go through some of the slides on data, a little on the quick side there because you've gotten a sense and a flavor, so I won't spend a whole lot of time on that. Here, taking this quote from Sir Ernest Rutherford, and at the time, and actually I could have changed it a little bit and said, gentlemen, ladies and gentlemen, we've run out of money, it's time to start thinking. And I mean, and that's really where we are today. We have no money, and we really need to be thinking about how do we best approach our problems because we're out of dollars. And we hear that constantly, and as you saw the new unemployment numbers come out, we're in a worse state. So what I'm going to do is I'm going to quickly just give you an overview of the morbidity trends in the northeastern states, some examples of social determinants. That third bullet, forget that. I should have taken that out. Due to time, I don't have a lot of time to go through that. And then I'll end with some approaches that I think you guys should consider. So with that said, very quickly here, again, like Donna pointed out, with the disparities that exist with HIV, nationally, we've got the same issues on the STD side. You look among African Americans, they count for 48% of all the chlamydia cases in the country. The ratio there, black to white ratio, 8-to-1 for chlamydia. You look at gonorrhea, 20-to-1. African Americans account for 71% of all gonorrhea cases in the nation. Now, we did in 2009 see a slight decline of roughly about 40,000 fewer cases. However, the disparity is still very huge among African Americans. And then looking at syphilis, primary and secondary syphilis, the most infectious, you've got a 9-to-1 black-white ratio. And what's really driving the primary and secondary syphilis is really among adolescents, or I should say teens. Between the ages of roughly 15 to 24, you've got huge disparities in that population of color. Quickly going through, looking at the northeastern states, the thing that I really want to highlight as I go through some of this, and again, this is where it's important in talking to communities about disparities, we've got that other category sitting there huge. And so if we don't come to grips with that and we're talking to communities about disparities, you can highlight the disparities that exist among African Americans and Hispanics, but if you haven't addressed the other, we've got to do that in order to get a better sense about really when we say disparities, who are we really talking about here? Because again, not knowing who the other is, that could affect and have an impact on the disparities. But again, looking at Connecticut, 34% of your chlamydia cases are among African Americans, 51% of your gonorrhea cases are among African Americans in Connecticut. Looking at Maine, 78% of your gonorrhea cases are among whites, 71% of your chlamydia cases are among whites. And I'm going to get further into the determinants about really what this means because, again, I don't think that we have, just looking at the numbers, a very true picture of, again, what this actually means. Massachusetts, again, 39% of other. Again, looking at chlamydia, that is, again, significant. But looking at gonorrhea, 32% of all your gonorrhea cases are being diagnosed in African Americans. New Hampshire, again, for the most part, the cases for gonorrhea and chlamydia are among whites. New Jersey, 32% of your chlamydia cases are among African Americans, more than half of your gonorrhea cases are among African Americans, and almost half of your primary and secondary syphilis cases are among African Americans. Again, the other. I mean, other would be great if it was a race, but again, looking at New York, again, the disparities that exist there, but bringing, again, the attention to the other. We've got, again, to do a better job of collecting that data about what we're talking about with race and ethnicity. Pennsylvania, the thing that stands out here, almost all of your cases here of primary and secondary syphilis are among African Americans. Better than half your cases of gonorrhea among African Americans. Puerto Rico, almost all your cases there, are among Hispanic and Latino populations. But again, I'm going to drill down as to we really looking at this number does not give you a very true picture when you just look at the data itself. And this is why social determinants are important. Rhode Island. You see here, again, we've got an issue with other, but 65% of your syphilis cases are among whites, and almost all of your cases, I think that there was only one female case, almost all of these cases are among men, which is an indication of men having sex with men. Vermont, again, looking at gonorrhea and chlamydia, a majority of those cases are among whites. So, this is the view from above is what I just gave you when you look at the numbers. And all too often what I see, unfortunately, even us at CDC and nationally, we get a little jacked up on these numbers and we all freak out on the numbers. But the numbers don't give us a very true indication of what's happening. And so this is why I think we need to drill down. And this is where we get into social determinants. And social determinants, again, there are social determinants with policy, with environment, with systems and cultures, and we all have to take that into consideration. Looking at social determinants of health here, when you look at policy, I'm going to give you a bad policy and a good policy. The bad policy, the 3-strike laws. We all got a little hyped up and jacked up about that because it was a great political win. But at what cost? At what cost? When you look at California, $750 million per year in California that they pay to house 3 strikes. That's a dollar amount that we really cannot afford nationally. And look at who we are imprisoning. Mostly African Americans and Hispanic populations. And the reason why we would not do that to whites, because just think of the uproar if this was different. It would not be acceptable. And as Donna pointed out, this is having an impact on the social networks in African American and Hispanic communities. And so again, what I would encourage people to do and what we need to do as in this country, when we look at these policies, at what cost and who is it impacting? Because I don't think, actually I know, we cannot afford $750 million to lock folks up. Just for, this is my 3rd offense and I stole pizzas or something like that. I mean, there are examples of just that. A good policy here. You look at what Bank of America Charitable Foundation did, and this is in New York in 2006, where they worked to have a program to immunize children. Again, this is working with private foundations, working with academia and the community to address an issue around vaccination. Determinants shaped by environmental factors. Donna talked about the low educational attainment. When you look in the United States here, 47% of African American males graduated from high school. 47%. For Alaska, American Indians and Alaska Natives, it's even worse than that, looking roughly at about 32%. What does this mean? Well, if I don't finish high school, what are my overall opportunities for supporting a family, getting a very good job, again, making as far as a male, making me available for marriage? All of that is a factor that drives what we see in these huge determinants. Because what I should have started out with, now I'll get to that later. 68% of our U.S. state prison inmates are high school dropouts. Again, if we put and truly invest in educating our citizens, we can have an impact, a positive impact on a lot of the determinants here. United States, where we rank 20th in high school completion rate among industrialized nations, 16th in college completion. Again, there is room for improvement when you look at this environmental factor here. And just to highlight here where we are with this environmental factor as far as education, where you've got well-resourced, high-performing schools, Asian Americans, whites, Native Americans. And this speaks to poverty on the FARL. This is the free and reduced lunch program. And so that speaks to poverty. And again, that is really when I was highlighting some of the issues there in Vermont and Maine among the whites. Drilling down is you will get to the issue around poverty. Because one of the biggest things is, I'm getting a little ahead of myself, but I'm going to repeat myself. One of the biggest myths and stereotypes we've created in this country is there's no such thing as poor white people. That is one of the biggest myths and stereotypes we have done in this country, and really that's had a profound impact because we have created policies, draconian policies, because we put up front communities of color, but we've got poor whites in this country that are being impacted by our policies. But again, we are under the myth and assumption there's no such thing as poor whites in this country. When you look at students in poorly resourced, low-performing schools, again, look at African Americans, look at Latinos, look at poverty there on the reduced lunch. Again, looking at that, that takes into every citizen, every race and ethnicity when you look at the free and reduced lunch program there, and that's why I've got that highlighted there. Native Americans, again, look at how we are really doing a disservice to our citizens in this country. How does this have an impact on STIs? When you look here on the left, look at among African Americans as far as high school, less than high school at the rate. 35%, and you look at who is graduating from high school, who's gone on to college versus white. Then on the flip side there on the right, look at where we are with the use of condoms. But the real main thing here is high rates of STDs are being driven by those that are out of school, that did not finish high school, did not go on and finish college. And so again, looking and drilling down on the numbers, it is less looking about the numbers and more about who are we talking about when we highlight these numbers. Social determinants of health here, when you look at systems, there are institutional biases. How a physician or a healthcare system treats communities of color. Early on in the HIV epidemic, when we got heart medication, you had doctors that would not prescribe heart to communities of color because they didn't think that you were going to take the medication correctly, didn't think that you were educated enough, and so decisions were made based merely on the fact of color. Again, I kind of talked about some of the stereotyping and prejudice, some of the other stereotypes that we have. And really, I could have started out with the questions that are often said, and as Donna said, it's a little bit challenging for us. People do often say, well, what's wrong with folks of color? Why can't they get their stuff together? They have all this sex, they got all this disease. I mean, people ask, in private settings, you ask those questions. I would say those are the wrong questions. It's not that, asking the question, I don't have an issue with that, but it's the wrong question. The better question is, like I said, who are these folks and what are they impacted with? What are they faced with? Education, poverty, and some of our own policies are driving a lot of these problems. And so, again, when we talk about the stereotypes and prejudice, we need to come to grips with that so we can have a better understanding about these determinants. Cross-cultural education and training of health professionals. Again, it's important that professionals understand people's culture on how they receive information, how things are dealt with in their communities. Oftentimes, health professionals don't understand. And we have made huge mistakes time and time again in the health profession. What I mean by that as an example, let's say that, and Donna kind of alluded to that, if as an African-American female, I only have one partner. I come in, I'm diagnosed with chlamydia. Now here I am, and I'm the physician. I've now diagnosed you with chlamydia, I'm treating you, and now I'm telling you that you must use condoms consistently. You must always use condoms without taking into consideration, because what happens in these institutions, I don't believe you just have one partner. I think that given the fact that you're an African-American female, you're having lots of partners, you're just not being honest with me. And so I berate you about you not consistently using condoms. But in thinking about it and understanding, condoms really doesn't work for this individual. I've got one partner, one steady partner. How do I introduce condoms into this relationship and I've got only one steady partner? Again, understanding the dynamics and the culture that exists, this is where we've got to do a better job of training our health professionals. It is not cultural competency. In fact, I hate that term. It's more than that. It's truly understanding what happens in these communities. Policies and infrastructure to address the multiple needs of diverse clients is lacking. What we want to do is think one size fits all. What works for one African American, what works for one Hispanic, what works for one poor white, it applies to all. It doesn't. What we've got to do a better job is, again, understanding that multiple needs are important for multiple populations. Determinants shaped by culture. With the social media now, you can go anywhere and get hooked up and get laid to your heart's content. There's Facebook, there's Twitter, all kinds of ways that you can have sexual encounters. As opposed to fighting that, we need to understand, how do we educate our youth about these social media? We've got to truly understand. Like, now I'm too old for tweeting and twittering. I don't get into all of that. The Facebook page, I do have one, and that's to keep up with my 25-year-old daughter. But again, we've got to understand, how do we best educate ourselves as we get older, and how can we use this in a positive way? Looking here as a determinant shaped by culture, we don't have kids exercise. You look at that age 8 to 18 on average, most of the time they sit around and you think, what does this have to do with STIs? It has a lot. Because again, video games, televisions, and computers, they multitask, and so you think that we're going to be able to educate kids about STIs by having someone like me stand in front and talk to them. They're not prepared for that. Because looking at how they multitask, because I mean, I'm sure a number of you have kids that they go ahead and text. My daughter, once she gets in the car at 17, she's texting and talking to me and texting. And so we've got to come up with better ways on how we go ahead and engage them, because they do so many things at different times. I don't even know how they keep up with some of this craziness. Okay, so what are some of the strategies we need to be thinking about to reduce and eliminate disparities? Here I'm going to give you what I think you as legislators should be considering here to reduce disparities. Here you see the first one there on creating incentives for private providers and hospital systems and communities to work together. And what I should have started out with, it is less about more dollars, because I know as legislators you're faced with that. People come to you and they think that you can move heaven and earth, and this is a particular policy that I'm vested in, but it costs money. What I would argue is that what we need to do is evaluate and realign what the existing dollars are. It's not necessarily new money that needs to be, or more money that needs to be added to the table, but some of the stuff that we have in place we need to drop altogether or do something different. And so one of the things here is that I've got pointed out here, that really we need to include private providers, communities, hospital systems, and others at the table to address some of these problems. And looking at some of the potential outcomes, you've got communities are involved in evaluating service gaps. And truly what this is, the communities have an up and down vote about what happens in their communities. You get better engagement, you get better participation when you have that happen. As an example here of what I want to point out, we've got this thing here that the U.S. Department of Agriculture has had since about 1914. It's called the Cooperative State Research, Education, and Extension Service. And this was a way of helping small farmers and small communities, and really build up the farmers and make the communities more viable. What we can do is we can take that example, that model, and come up with county-based health extension organizations to support primary care, because as Kevin pointed out, that's going to be the driving force, and we don't have enough primary care providers right now, but that is the future for us. And what it will do is we're going to build up infrastructures in these communities. It will create jobs. It will create opportunities. And so I would suggest looking at that model and looking at using that model as a way of really having an impact at so many different levels, at the community level, at the provider level, and ultimately building healthy communities. Another example here that I think that we need to look at is the state and local problems created by the care is not coordinated. all too often what we do is we look at things by disease as opposed to population. And so what we need to do is move away from a disease-sick model to a population model. And just as an example here in New York City, the STD program, what they did is they knew and realized that there was an issue among the population around substance abuse. And so in the STD clinic, what they did through a grant, they put together a substance abuse screening program so they could go ahead and then, right then and there in the STD clinics, have an opportunity to do the screening, do the intervention, and the referral all in that one visit. As opposed to you identify somebody with a substance abuse problem, then you send them someplace else, and the likelihood that they're going to go is probably slim and not at all. Again, coordinating those efforts as opposed to having these different systems that we have. Another example or something that I think that you should be mindful of is how do we manage and promote the protection of health by reducing some of this fragmentation? And here is an example of a gonorrhea community action project that was initiated in 1998. And this was actually it was a national program, but what I'm highlighting here is from New York City. And basically what this was, they brought communities together along with state and local health department folks, and they really honestly informed the community about the huge rates of gonorrhea that were existing in those communities. And they put together 3 intervention models really helping those that were impacted and affected by gonorrhea on what they could do. And this was working with private providers and the community to make this happen. And so again, developing and creating policies that really have a better impact on communities and bring so many other people to the table. And it's less about, like I said, adding new dollars, but looking at existing dollars and realigning them. Here is an example of bringing academia together, foundation, and communities together, as well as state and local health departments together. This is out of Pittsburgh, Pennsylvania here, using, as you can see here, Robert Woods Johnson Foundation money and other foundation money to really launch this program around hypertension and obesity among African American communities. And again, looking at bringing different and diverse bodies to the table. And this is folks that have less to do about health, but they are concerned about communities that are impacted by disease. And so again, this is something that as a legislative body you need to be thinking about. How do we encourage diverse bodies to come together at the table to address these problems? Again, less about we need to bring in new money, but again, looking at existing dollars, looking at existing resources, and pulling them together. Finally, with that said, we may have all come on different ships, but we're in the same boat now, and this is from Dr. Martin Luther King. The best example that I think of this today is the Carnival Cruise. You remember that Carnival Cruise that went kablooey out in California? You think about that situation, that here you had folks, they came on that cruise for all different reasons. Some honeymooning, some this is the 50th wedding anniversary, a whole host of reasons why people came on that cruise. But as we all know, it broke down in the middle of the ocean. So there we all were, you know, different communities of color, rich, poor, you have it, they were all there on that ship together. No food, no flushing toilets, no air conditioning. And so what did they have to do? Well, they called on the U.S. government. Help me out. So what happened? The Navy comes out, we're going to give you Spam and Pop-Tarts. Now, when you haven't eaten in a while, Spam sounds like filet mignon. And Pop-Tarts are like a delicious chocolate cake. But the thing of it is, and the example that I want to draw is, this is where we are today with healthcare reform. It wasn't perfect. It isn't perfect. It didn't give us everything, but it met the need for right then and there. It was an opportunity, and it is an opportunity to build on that. Now, with that said, when you look at what happened on this great cruise, you look at the president of Carnival Cruise Line. What did he do? He didn't worry about dollars and cents. He didn't say, oh my God, screw it, forget it. He valued each and every one on that ship. And you look at it, not one person complained when they got back to land. The problem we have in this country is we do not value each and every one. We've got to do a better job of valuing each and every citizen in this country. All too often what is happening today, it is about winners and losers. When we have that mindset, we all lose. And that's where we are today. We're all losing. And I go back to, as Martin Luther King pointed out, and what happened with that Carnival cruise ship, they valued everybody. And when they got back, you didn't hear one complaint. You didn't hear anybody say, you know, I'm never taking another damn cruise again. Screw Carnival. They didn't, because they knew they were valued. Thank you.